How's it going, guys? It is 2:27 a.m., 13th of April. Here in Japan, we have a medium difficulty question for step one, pass level question for 2CK. Before we start, please subscribe to the channel. Really appreciate it. Give me a like. Really appreciate it. Find me on Instagram. Mehlman_medical, mehlman_medical. Links down below. Find me on Telegram. Links to the Telegram group and channel down below. Answer the clip. 60-year-old woman. She has a 1-year history of progressive fatigue. Laboratory studies show MCV elevated. 110 should be 80 to 100. B9, B12 normal, calcium elevated 10.4, mill equivalent bleeder should be 8.4 to 10.2. And then you've got this recondite blood smear here. You say, no idea what I'm fucking looking at. All right, well, we'll just hop through the answer choices. Choice, questions asking which the following most likely be seen as patient. Choice A, 20/200 transitory visual acuity, obscure answer choice, wrong fucking answer. Refers to, in theory, multiple sclerosis, optic neuritis. Okay, they like giving you abnormal visual acuity, changes in color vision, central scotoma. It could be seen in hyperviscosity syndrome. Okay, blurry vision, headache, Raynaud phenomenon. Okay, in this case, wrong fucking answer. Choice B, hematuria, wrong fucking answer. So this condition, this question, can cause nephrotic syndrome. It's not going to cause hematuria. It's not going to be a nephritic syndrome. So this is multiple myeloma. Okay, so I didn't give you the back pain and the Bence-Jones proteinuria, all that. I mean, question doesn't have to be that buzzy, but this image is showing you clock face chromatin. So if you look at basophilic means purple. So if you look at these large basophilic nuclei here, the even darker purple, even more highly basophilic areas within the nuclei are supposed to be, if we hallucinate, they're supposed to be arranged in a clock face chromatin type of manner, okay? Not my fucking opinion, all right? This slide is buzzy. I have it in my high-yield hematology PDF. Okay, I just jacked this image off Wikipedia, increase the contrast, saturation, whatever, so it's easier to see, but you need to know this image, all right? So don't worry, I'll link the PDF below. But multiple myeloma, you're going to have a plasma cell neoplasia, which plasma cells are B cell origin. They secrete immunoglobulin. So immunoglobulin light chains, IgG kappa lambda light chains, immunoglobulins are proteins. So proteins depositing where they shouldn't be depositing is called amyloidosis. So multiple myeloma is the highest yield cause of renal amyloidosis on USMLE, which is a nephrotic syndrome, not a nephritic syndrome. Okay, it can also cause cardiac amyloidosis, diastolic dysfunction. So hypercalcemia, lytic lesions of bone, calcium just leaches out of the bone. Pepper pot skull, if you do an X-ray of the head, you can get increased erythrocyte sedimentation rate. So these IgG kappa lambda light chains will stick to the surface of RBCs, and then you get rouleau formations. Choice D is the correct answer, okay? That's why your ESR is elevated, is because rouleau or roulette, they are heavier, okay? So I'm just going to continue here. The IgM M protein spike, wrong fucking answer. This refers to Waldenstrom macroglobulinemia. So M refers to monoclonal protein spike. In multiple myeloma, we have an IgG. Holy shit. IgG kappa lambda spike. Okay, so serum protein electrophoresis, 2CK. They'll give you the same fucking question. So what's the next best step in management? Answer is serum protein electrophoresis. And then after that, they want bone marrow biopsy. Students will say, well, what about getting proteins, looking for the Bence-Jones proteinuria? I agree with you. Okay, but in terms of what USMLE, what I've seen on forms is they just want serum protein electrophoresis, SPEP, followed by bone marrow biopsy, which is going to show you greater than 10% plasma cells. That's how you diagnose multiple myeloma. Under 10%, we call that MGUS, monoclonal gammopathy undetermined significance. Around 10, we call it smoldering myeloma. USMLE doesn't really give a fuck about the latter two, okay? You just need to know greater than 10% plasma cells, multiple myeloma. So in Waldenstrom, no hypercalcemia. You do not get Bence-Jones proteinuria. You have this IgM M protein spike rather than IgG as with multiple myeloma. And in Waldenstrom, you get hyperviscosity syndrome, okay, as I said. So headache, blurry vision, Raynaud phenomenon. And Waldenstrom is a plasmacytoid cancer. Oid means looks like but ain't. So the cells look like plasma cells, they ain't plasma cells, okay? So I talked about how rouleau formation, correct answer. S3 heart sound, wrong fucking answer. You need to know 29 out of 30 times on USMLE. S3 heart sound will mean systolic dysfunction, or it can be seen in pregnancy sometimes, or in high endurance athletes, okay? one question out of 30, one question on, I believe it's Internal Medicine Form 7, 2CK Clinical Master Series. They give it for diastolic dysfunction. I swear it's an erratum, okay? But I'm just pointing it out in case you encounter that at some point, those of you studying for 2CK. Literature doesn't confirm it, but I'm just saying, 1 out of 30 questions, diastolic dysfunction. 29 out of 30 times, you need to S3 is systolic dysfunction. So cardiac amyloidosis, diastolic dysfunction, S4 heart sound, basically always. And in diastolic dysfunction, you have a preserved ejection fraction, increased left ventricular end diastolic pressure, normal left ventricular end diastolic volume. Okay, so the volume's not decreased. You just require more pressure in order to achieve the same volume. It's a long fucking discussion in terms of all the cardiac phys. By all means, I'll just link my cardiac PDF below. You know the deal. To make more content, like my stuff, subscribe my channel. I appreciate your time. That's it.